Now coming to the differential diagnosis. So we do have a strong clinical suspicion. We go for nerve conduction studies. But there are certain differentials that we might consider, we have to consider. So one is whether we are dealing with post-viral anterior horn cell infection or not. For example, associated with enterovirus 71, rabies virus, and HIV associated with opportunistic infection can also present with similar clinical features. So whether we are dealing with acute transverse myelitis or not. So we have to remember that in acute stages of transverse myelitis, that is involvement of the spinal cord, we can see the patient in the shock stage. So what is shock stage? In very early stages, we can have only lower motor neuron type of features which can mimic a neuropathy. We won't have upper motor neuron signs per se. So that is when it gets confusing with GB syndrome. But we have to take a very detailed history that whether there is any sign of a myelopathy, such as a definite sensory level, if there are any brisk reflexes anywhere in the body, and if there is a clear-cut history which suggests a myelopathy instead. And if there is a prominent sphincter problem or bladder and bowel dysfunction, that is, if there is a urinary retention, if there is urinary incontinence or constipation, which is of acute onset. So we have to rule that out, and then we might want to order one MRI scan of the spinal cord to establish or refute a transverse myelitis. Acute peripheral neuropathies. So as we are discussing AIDP or acute inflammatory demyelinating polyneuropathy. So there's also another entity which is a chronic inflammatory demyelinating polyneuropathy, which can present acutely. They can have an acute presentation. So it is important to go through the history and the electrophysiology to consider a possibility of acute onset CIDP, because the prognosis differs, the natural course of the disease differs, and so that is how we explain to the patients and the relatives. Then comes the other possibilities such as porphyric neuropathy, tic paralysis, or Lyme's disease. So we also have to remember that neuromuscular junction disorders can present with problems or clinical signs and symptoms which can mimic GB syndrome. So there can be diplopia or gaze restriction, there can be ptosis or drooping of the eyelids. So we have to be extremely careful to ask the history of whether the weakness has a diurnal variation, whether they are well during the day, and as the day passes by, whether there is any worsening or not, right? So this is very important, and along with that, a targeted clinical examination. That is, we have to test for fatigability, whether after exercising they're getting fatigued or not. And also there are certain electrophysiological tests such as repetitive nerve stimulation test or single fiber EMG, which can help in establishing a diagnosis of a neuromuscular junction disorder. And also there are various antibodies which can be tested from blood, which can establish a diagnosis. So the treatments differ, so it's very important to differentiate. Then comes muscle disease. We have to be careful whether we are dealing with acute myositis or not. We might want to get one CPK done. We'll have to do an electromyography or EMG to see whether there are myogenic potentials or not. And also there are channelopathies, problems with the channels, so such as acute hypothalamic periodic paralysis and thyrotoxic periodic paralysis. So they can present with weakness and quadriparesis, but say for example hypothalamic periodic paralysis, after replenishing potassium, they can get better. So it's important to have an open mind and think of other differentials. Now coming to critical illness neuropathy or myopathy. So students, in critical care setting, it's important that what is the setting in which we are seeing the patient. If it's in a critical care setting and they have prolonged hospital stay, ICU stay, they were ventilated, intubated, They might have needed neuromuscular blocking agents. So then there are certain features in the electrophysiology when we can say that we are dealing with critical illness neuropathy. So the treatment and the natural history varies. And then the diagnosis of exclusion is a functional neurological illness. So when everything is normal, all the tests are normal, but still the patient is complaining of weakness, we have to keep this in mind, whether we are dealing with a functional neurological disorder, somatic manifestation of a mental health condition. Now, what are the red flags for diagnosis? One is fever at onset. Then if somebody complains of severe sensory signs and sharp sensory level. So usually it's a motor predominant neuropathy, although we do see sensory affection in some variants, but a predominant sensory sign would indicate us to an alternative diagnosis, and a sharp sensory level might signify a myelopathy or a spinal cord involvement rather than a nerve involvement. Chest problems or pulmonary dysfunction. Some patients might have persistent bladder and bowel dysfunction because this might signify that there is a spinal cord affection. So there can be some urinary symptoms in GB syndrome, but if it's predominant and if it is persistent, then we might have to think of an alternative diagnosis. And also, severe pulmonary dysfunction with limited weakness is another red flag sign. There can be marked and persistent asymmetry of the weakness. So as we know in GB syndrome, there can be asymmetry at onset, but quickly it becomes symmetric. But if it's a marked and persistent asymmetry of weakness, we should think of another diagnosis. So coming to the case, so with our knowledge that we've just discussed, so let's look at a case, a real world scenario. So a 37-year-old lady came to the clinic with history of loose motion or diarrhea 14 days ago. She developed fatigue and lower limb pain and difficulty in climbing stairs for last 4 days. So there's no history of bladder or bowel involvement or bulbar dysfunction. The weakness eventually progressed to involve the upper limb. So what do we see here? A young lady with a history of diarrhea developed progressive weakness of lower limbs, which was followed by upper limb weakness. So she had lower limb pain, which may be seen in GB syndrome, and she also had difficulty in climbing stairs. So when we get a history of somebody having difficulty in climbing stairs or difficulty in standing up from a sitting position, we think of a proximal muscle weakness, which is seen in GB syndrome. That is proximal thigh muscles, quadriceps. If there's weakness in the quadriceps, they can have difficulty in climbing stairs. So there was no history of bladder bowel involvement or bulbar dysfunction. So it's limb onset dysfunction, no sphincter complaints, and no bulbar dysfunction. So on physical examination, she had proximodistal weakness of lower limbs more than upper limbs. All the deep tendon reflexes were absent and the sensory system within normal limits. So the electrophysiological studies, that is the nerve conduction study, showed prolonged distal motor latencies of nerves tested in lower and upper limbs, absent H reflexes and F waves, along with temporal dispersion in the CMAPs, and sensory snaps or sensory nerve action potentials were within normal limits. So we find a predominant motor affection with sensory nerve sparing, and the feature is consistent with a demyelinating pattern of neuropathy. So on CSF study, we saw that the cell count was 2, but the protein was very high, that is 140 milligram per DL, and the glucose was normal. So this feature was not consistent with a CNS infection. So this was something which, as we discussed, is albuminocytological dissociation, so which is classical for GB syndrome. So the diagnosis is AIDP with widespread symmetric and ascending motor predominant demyelinating polyneuropathy, along with supportive evidence from the electrophysiological studies as well as CSF study.